Hi, Denise here, doing my last paper for Research and Evidence class, Module 8. Denise Winters. The clinical problem I chose all stemmed from a research question asking why people who are clinically ill decide to hasten their death and others do not. Originally, I wanted to know if those that chose not to hasten their death were because of fear or religion. I also wanted to know if those who decided to go forth and hasten their death, was it done so because of pain? It has been a long research journey analyzing data, literature, and methods used to gather evidence and learn ways to determine if the information collected is qualitative, sound, and reliable. As the process of gathering more insight into why a terminally ill individual would or would not choose to hasten their death, the answer became more apparent each week. Ultimately, it boiled down to the control and religion. Those who decided to hasten death wanted to have control over something at a time when they had lost control over everything else. Those that chose not to, most commonly it was due to religious reasons. However, it seems there was always a looming issue in the background of all the literature, the right and the wrong factors for a professional healthcare provider to assist in the death. The Association of American Medical Colleagues states that by 2023, primary care physicians will be shortened by 55,200. The changes that reflect in the nursing world are increasing autonomy and responsibility. The opportunity for advancement in practice for nurses has blossomed dramatically. The advancement degrees vary in a specialty area and create a trusted partnership bond between the physician and the nurse. The advancement nurses are leaning towards becoming a nurse practitioner. This is according to the Global Health Education of 2020. Based on that evidence, an RN is likelier to supervise and assist an individual dying with dignity. The nursing creed reflects that service shall be provided with humanity, consciousness, and dignity, and a patient's complete health should be the first consideration. Registered nurses are autonomous healthcare professionals that take pride in providing protection, encouragement, and empowerment to their patients. Based on the information listed above, why is there an ethical war against assisting a patient that is suffering from a terminal disease to leave this world on their terms, peacefully and with dignity? The book Code of Ethics for Nurses with Interpretive Statements, Provision 6.1, states that moral character is to do what is right with integrity, respect, moderation, and for the industry of whom we encounter. The nursing practice speaks about moral uncertainty and more dilemmas. Does the debate revolve around what is ethical and of moral character? As nurses, we are taught to do no harm and strive to help people survive and live. We do not take their lives away. However, when a person is slowly stripped of their independence, mental control, physical abilities, dignity, modesty, and quality of life, and pleads with the physician to just die, what happens then? The conception of death with dignity is a conception of, quote-unquote, death, and is taken to apply to the process of dying, quote-unquote, dignity. It is assumed to be something that attaches to people because of their personal qualities. In particular, someone lives with dignity if they live well, per reason. It follows the healthcare professionals cannot confer on patients with either grace or death with elegance. They can, however, attempt to ensure that the patient dies without indignity. Indignity are affronts to human dignity and includes severe pain, and the exclusion of patients from involvement in decisions about their lives and deaths. This relatively modest conception of death with dignity avoids being overly subjective or viewing the sick and helpless as undignified. In many of the research articles I found, the researchers performed studies in hospitals, in hospital cancer centers, and with physicians asking their opinion or the number of times that they have been asked to assist a person in dying. The studies were qualitative and used data collected from the surveys or interviews. Surveys on attitudes toward assisting dying are essential in informing public debate, policy, and legislation. Unfortunately, surveys are often designed with insufficient attention to the framing effects affecting the respondents' stated attitudes caused by question wording and context. Therefore, using a standardized, credible, and reliable questionnaire that has been used in the past with results that can be replicated easily with minimal confusion is best. The theoretical model I would use to overcome barriers starts with Elizabeth Kubler-Ross. She is the author of Death and Dying, written in 1969, in which she proposed the now famous 5 stages of grief. The 5 stages of dying and grief are denial, anger, bargaining, depression, and acceptance. Acceptance. Some people in life never reach that stage. Some of them stay in anger, some of them stay in depression. So some of them never reach the acceptance stage. Some people reach that stage quickly. Once the person is accepted, they are dying, and the process in which the disease will take their life. The choice becomes preparing for the long haul of medical dependency, palliative treatment, and hospice. Imogene King developed the theory of goal attainment in the early 1960s. It describes a dynamic interpersonal relationship in which a patient grows and develops to attain specific life goals. The theory explains that factors can affect the attainment of set goals. The model has 3 interacting systems: personal, interpersonal, and social. Each of these systems has its own set of concepts. The concepts for the individual system are perception, self, growth and development, body image, space, and time. The ideas for this interpersonal system are interaction, communication, transaction, role, and stress. The social system concepts are organization, authority, power, status, and decision-making. Now think about Imogene King's goal of attainment model. If you were just told that you have ALS, how does ALS change your life in the 3 different interacting systems in the model of Imogene King? Changes. He or she has the ability to, this is a quote from Imogene King, he or she has the ability to perceive, think, feel, choose, set goals, select means to achieve goals, and make decisions. He or she has 3 fundamental needs: the need for health information when it is needed and can be used, the need for care that seeks to prevent illness, and the need for care when he or she cannot help him or herself. According to King, a human being refers to a social being who is rational and conscious. The statement is the need to care when he or she cannot help him or herself. How does that apply? This can be palliative, hospice, or assisted death. It is based solely on the individual's decision in that situation. King states that the goal of a nurse is to help individuals to maintain their health so they can function in their roles. The domain of the nurse includes promoting, maintaining, and restoring health and caring for the sick, injured, and dying. The function of a professional nurse is to interpret information in the nursing process, plan, implement, and evaluate the nursing care. Based on the theory of goal attainment, which is defined as the process of action, reaction, and interaction by which the nurse and the client share information about their perception in the nursing situation, in which they set goals, agree on means to achieve those goals, and those goals are placed into a sequence of behavior involving mental action, physical action, and reaction. The sources of internal evidence that will provide data supporting reasons why death with dignity is a choice terminally ill patients can advocate for comes from one website. The website is called deathwithdignity.org/resources. It has peer-reviewed articles on death with dignity. The website has organized the articles by topic: implementation of legislation, legal challenges to legislation, death with dignity laws and end-of-life care such as palliative sedation and voluntary stopping of eating and drinking, ethics of death and dignity, and people with disabilities. Ethical considerations are always a concern with anything. An essential distinction is utilitarianism. It concerns itself with the consequences of individual actions, utilitarianism, or with the overall implications of having particular rules, rule utilitarianism. Act utilitarianism would ask the personal health professional to consider for each patient whether the potential health benefits for this patient are sufficiently positive to merit the cost of medications, pain and suffering, depression, loss of control, inability to participate in activities that once were pleasurable, and loss of dignity. In contrast, rule utilitarianism focuses on developing general rules to apply in such cases, regardless the particular features of every individual case. In the case of act utilitarianism, the individual is responsible for assessing and comparing the likely consequences of their potential actions. In the case of rule utilitarianism, the focus is on decisions about the most advantageous rules to follow for society. Decision-making about the best utilitarian rule is left to us experts with the authority and power to implement society regulations, such as laws, education, and incentives. In the case of nursing, the implementation of utilitarian values remain in the hands of the nursing bodies, which determine the values and rules of the nursing code of conduct and who determine how nurses are educated. Individual nurses would primarily be expected to apply those rules rather than make utilitarian calculations about likely consequences. In general, utilitarianism highlights that our action consequences are essential for understanding our actions' morality. The same move might be right in one context but wrong in another. So killing a person might be considered inappropriate by utilitarianism when it ends a life that would have been characterized by more pleasure than pain. However, it might be regarded as right under some circumstances if it completes a life that would otherwise have been characterized by terrible pain. Honestly, I never had any intentions of operationalizing anything. I had a curious question, and the question was answered. However, as curiosity does, I am now curious if this kind of education and information were made available via seminars, flyers, or social media, would people ask their doctor